We can examine the difference of schizophrenia versus bipolar disorder under these terms. Here we can see some theories of how they interact with each other. Some say that they are two distinct groups, others that there is some noise between them, some patients that we can do easily differential diagnosis, others that the noise is bigger. There are a lot of patients who meet the criteria for both diagnoses, so we have uncertain grouping for most cases. And finally, there are those who consider them a single group and that the subgrouping is due to bias. Examining the clinical manifestations for both diseases, we can observe that apart from the cause, in schizophrenia it's chronic and in bipolar disorder cyclical or episodic, and some qualitative differences in areas such as lifetime suicide risk, substance abuse, or neurocognitive deficit and some soft neurological signs. I think that Dr. Karavelas will talk about this later after me. The strongest difference between them concern mainly the presence of manic episodes in bipolar disorder and less so the presence of negative symptoms in schizophrenia. Neurocognitive deficits in bipolar disorder share some same common characteristics as those seen in schizophrenia, mainly in the domains of attention, executive functioning, working memory, verbal learning, and psychomotor performance. A possible significant difference, as we already stated, is the higher than normal premorbid intellectual functioning for patients with bipolar disorder in comparison to schizophrenic ones. We can see the usual course of both schizophrenia and bipolar disorder. As we said, the course of bipolar disorder is episodic in comparison to the constantly decreasing course of schizophrenia. Although there seems to be a better outcome for bipolar patients, this difference is possible just mainly statistical. Schizophrenia and bipolar disorders are transmitted independently. Schizophrenic probands are at an increased familial risk for unipolar depression and schizounipolar subtype. Depression in schizophrenia is not solely either a reaction to having had a psychotic episode or part of the recovery process, and familial genetic liability to depression might increase the probability of the schizophrenic patients to experience depressive symptoms. In neuroimaging, the total brain volume in schizophrenia is reduced and the ventricles enlarged, when in bipolar disorder, more frequently are both unaltered. In schizophrenia, it's common to observe abnormalities of the white matter. In bipolar disorder, there might be hyperintensities in T2 sequences in brain MRI. Here we can observe the enlarged ventricles in schizophrenic patients, as well as the abnormalities of the white matter. Once again, we will hear more about this in the next speech. Genetics. There are genes that are common in both diseases, as well as different ones. Here are just some examples of these common genes. They both affect a similar proportion of the general population, with also similar numbers for their heritability, much higher than general anxiety disorder, panic disorder, or social phobia. It's about 80% for both of them, when in general anxiety disorder is 50%. That's the same for panic disorder, and 30% for social phobia. In studies with mono and dizygotic twins, the concordance rates of bipolar disorder is higher than those of schizophrenia. There is a dysregulation of both dopamine and GABA in both diseases. The therapy has proven to be efficient for positive symptoms and mania on one side, and secondary negative depressive symptoms on the other. It's not so efficient on primary negative neurocognitive and depressive symptoms. We don't know exactly how genetic and environmental factors affect these symptoms and in what degree. Here are some dopamine-dependent behaviors which are affected from the dopamine dysregulation, such as reality testing, cognition, reward seeking, and some of the consequent results of this affection. Diminished dopamine activity is implicated in cognitive impairment and negative symptoms. Enhanced dopamine activity in mesolimbic dopaminergic system is relevant for positive symptoms. Ability of neuroleptics to suppress psychosis is due to their T2 receptor antagonism. Drugs that increased dopamine transmission, such as L-Dopa, diamphetamine, and bromocriptine, might precipitate mania in patients with bipolar disorder. So the best response to treatment have the positive symptoms in both diseases and mania in bipolar disorder. Negative symptoms of schizophrenia don't have that good response. Psychotic depression responds better than bipolar depression. And it seems, though, that the neurocognitive deficit is the strongest prediction of the final outcome of the response to treatment. The most commonly used drugs in both diseases are, of course, the antipsychotics. They are the backbone of our effort to confront with both schizophrenia and bipolar disorder. Lithium and antiepileptics, the mood stabilizers, are first-line treatment during all phases of bipolar disorder, when in schizophrenia are used only as add-in for refractory cases. We should be cautious with the use of antidepressants in bipolar depression, and stimulants can be used as an add-in against depression in bipolar disorders, and they also may have some role to play against negative syndrome in schizophrenia. For conclusion, they both affect a similar proportion of the population worldwide. They have similar mode of onset, late adolescence, young adult life. The one has episodic course, bipolar disorder. Schizophrenia has a chronic course through the lifespan. They don't have similar social consequences. Schizophrenia is much worse. They do have similar suicide risk. They both are associated with substance abuse. They do have similar heritability. They have overlapping illness manifestations, but they do also have distinct features. They have different premorbid and prodromal manifestations. They do have a common biological substrate, but they respond to treatment with similar main compounds, but in a different way of use. Thank you very much. I hope I was quick so that the time we lost.
Thank you. If there are any questions or whatever you want to discuss, we will try to collect them for the end of this session. Thank you, Dr. Kyriazis.
Thank you.
Kalimera ξανά. I'm not going to present myself. I'm just going to say that this next presentation is about all that we could collect about the neurological soft signs concerning schizophrenia, bipolar disorder and unipolar major depression, brain imaging, and what other data there is published that has a meaning of that can be collected, or maybe some ideas will be there. For us, for anyone that doesn't know or doesn't remember what is neurological soft signs, we have to make this distinction. Hard neurological signs are those signs that we usually neurologists deal about, and they have to do about cranial nerves or unilateral muscle weakness or primitive reflexes, although this is an area that the soft signs also have to do something. And neurologists tend to use these hard signs to make a diagnosis. In contrast, soft signs are something that is there, but is not in a specific area, and of course it cannot lead to a diagnosis. At first, this was considered to be an artificial segregation and indicated that we could not understand why those soft signs are there and what's their meaning. We divide them usually in four groups: sensory integration, motor coordination, complex motor act sequence, and primitive reflexes. In schizophrenia, in patients with schizophrenia, the percentage of neurological soft signs are up to 100% according to some studies, depending always on the scale they're using, because there are scales with low sensitivity and low specificity, depending on if they are searching for one or more signs and so on. It seems like after meta-analysis, the percentage is up to 73% in patients with schizophrenia. This is from 2016, I believe it was published in April, if I recall, or in March this year. What we know now, but with bipolar disorder, there's very little data about bipolar patients and soft signs. We know that there are mainly signs in motor and sensory groups. The prevalence is higher than normal, and it was not found a correlation between those signs and socio-demographic and clinical features of these patients, except a negative correlation with the school level and global functioning. For depression, there is no data. We don't know. There's no studies. So we want to compare all these together in order to be more easy for us to see. In bipolar disorder, there's sensory signs. Also in schizophrenia, we don't know in depression. There are motor signs in both disorders. There are no complex motor and primitive bipolar in bipolar patients, although there is in schizophrenia. The percentage is up to 0.5%. Sometimes 100. You can remember that 80% of schizophrenic patients you can find those signs, and there is no clinical correlation in bipolar disorder, although there is in schizophrenia, which is a trait. It's not a state finding in patients with schizophrenia. Well, the data that we have for imaging are from those procedures, from CT, MRI, PET scan, and SPECT, all that you can easily find. So CT studies would use a computerized tomograph, reported a large lateral and third ventricle in up to 50% of schizophrenic patients, and some cortical atrophy in 35%. The studies that used MRI they showed enlarged third and lateral ventricles, decreased cortical gray matter, especially in the temporal cortex, and decreased volume in the limbic system, in amygdala, hippocampus, and so on, and increased volume in basal ganglia. The functional MRI showed increased cerebellar blood flow and lower than normal blood flow in patients with bipolar disorder. What we also know, or we think we know, is that there is a reduction in frontal blood flow. Hypofrontality is not a solid finding. It seems that there's much of controversy when we have, according to the studies that are available. Some speak with hyperfrontality, or some speak that there is nothing there. PET showed decreased activity in the anterior, cingulate, and medial frontal area in patients with reality distortion and negative symptoms mainly. Negative symptoms were related with hyperfrontality and some other findings, some that are not consistently, they're not there always, depending on the study and the process and what we use to find. This is, I believe, a known scheme, which this is a normal brain and this is a schizophrenic brain. And the gray matter loss is more or less shown here, also in this picture. The early and late gray matter deficit in schizophrenia. So the more the brain becomes purple, the more gray matter is lost. This is another slide for the ventricles. You see these lateral ventricles are really enlarged. Comparing with a twin, this is twins. Comparing with a healthy twin. Yeah, this is probably something that's not easy for anyone with Down syndrome to see, but it seems that gray matter, this is a study, it was a longitudinal study, and it measured gray matter volume with controls in schizophrenia, and the same people were measured 1 year after, and in 1 year it's shown that the volume of gray matter was decreased in schizophrenia. So what do we know about bipolar imaging? Although Odysseas told that ventricles are not altered, there are some findings, and probably the most common finding is that the third ventricle is enlarged. Less common reports, it's not Odysseus' volume, is the data's, it's not Odysseus' fault, it's the data's fault. Less common are reports of reduced volumes in the cerebellar and temporal lobes, white matter hyperdensities, also have been reported in some studies, cell loss in hippocampus and decreased number of density of glial cells. All this data that is there is not, it seemed to be in opposition with, some studies are in opposition with each other. That's the main problem. Some cortical abnormalities, again, amygdala and striatum, especially early in the course of illness. This is from a study that tried to measure specific brain areas, the volume of specific brain areas, in just when the diagnosis was there. And abnormalities in cerebellum and ventricles and other prefrontal regions appear later. It seemed that the same brain is, there's something there in the beginning of the illness, and despite if he's taking medication or not, the patient showed more and more abnormalities as the illness, as the disorder went on in the future. Some other abnormalities were there for membrane and syncope messenger metabolism in striatum and prefrontal cortex, and differences between bipolar and healthy controls in the same region shown by using fMRI. This is from 2012. This is few episodes. This is the same, and this is the same man. It's 6 years after multiple episodes. You see there's atrophy and enlargement of the ventricles. This is just one patient. Also here the control in the bipolar patient. You see there's a difference in the ventricles. This is the amygdala. This is the left amygdala, which is enlarged. And for depression, I must say there's more there for depression. There's smaller volumes in frontal lobe and cerebellum, caudate and putamen. Studies using CT showed non-specific differences concerning the ventricles. MRI studies report white matter lesions, especially in the frontal cortex and the basal ganglia. And there was evidence using PET and SPECT of decreased frontal lobe function. And there's variable changes. Variable changes means variable studies showing different things. Again, then the depressed brain, it's usually in the frontal cortex and the amygdala. Again, healthy and frontal cortex, you see there's no blood flow, there's no metabolism going on there. The hippocampus atrophy. Again, frontal area. This is a depressed brain. Let's say using different imaging. And to sum up all these things, ventricular enlargement is there in bipolar disorder, not yes in schizophrenia, yes and no in depression. Prefrontal cortex is associated with atrophy, is associated with bipolar disorder. Also, hippocampus, amygdala, cerebellum. The temporal lobe atrophy is there for schizophrenia and bipolar disorder. White matter loss seems to be larger in patients with schizophrenia, and basal ganglia are associated with unipolar depression and schizophrenia. So, other data. Other data is not, there's no other data that have been studied so much as imaging or the soft science. This is again from April 2016. This is a study concerning GABA. It seems that in schizophrenia, the reduction of GABA occurs in specific brain areas, and in old age, being probably mixed effect of chronicity of the illness, lifetime exposure to antipsychotics. Concerning bipolar disorder and major depressive disorder, we don't know yet. GABA could not be considered a biomarker of bipolar disorder yet. Because comparing to health controls, the only study that is there includes young and drug-naive patients failed to find differences. Probably if those patients were studied after some years of the illness, we could find something. And of course, the same thing seems to apply for major depression. And this is a study that included schizophrenic patients. This is what is going on now, which means that everybody's checking about cognition, and they're trying to see if cognitive deficits can be somehow studied using scientific and imaging methods. This is an unexpected reward, and a process with an experiment, and this is what the MRI showed, the response of the brain, specific areas of the brain. You see that in schizophrenia, there's no response, or the response is very little. Maybe it's compared with depression and healthy controls. This is from Harvard University. They actually did this, and they try to see if meditation does something to the brain. It's just for fun. Thank you.
Thank you, Professor Dr. Karavelas. If we have any questions? No. So we will continue with Dr. Ferentinos, who will talk to us about modeling bipolarity on the basis of evidence.
Good morning. Thank you all for being here this Sunday morning. And also I want to thank the organizing committee for the invitation. I'm going to talk about bipolarity. My talk has two parts. A first theoretical part on the bipolar spectrum, and a second one where I'm going to present our own data about a two-dimensional bipolar spectrum. So I'm starting the first part with this seminal paper in the American Journal of Psychiatry about the validity and utility of psychiatric diagnosis. We know we have a validity problem in psychiatry. Validity would be secured by a bimodal distribution of phenotypes, points of rarity, which have rarely been demonstrated thus far. However, our classification systems provide operational theoretical diagnosis with great reliability and utility, but little validity. How do we deal with that? We could use, therefore, the picture is like that. We have diagnostic nebulae instead of having strictly defined boxes of diagnosis. How do we deal with that? We can use dimensions, of course, but our brain is not very easy to think in dimensions. So we could actually merge dimensions and categories to spectra. So what is a spectrum? A spectrum is a group of heterogeneous but partially overlapping categorical diagnoses which are similar on several characteristics, and the categories are ranked along several dimensions that we can use to validate the spectrum. And what are the dimensions that are used as external validators of a spectrum? These have been very well described back in the 1970s, and are all these usual suspects that we are after in our research: genetic data, epidemiologic data, phenomenologic data, comorbidity, temperament, biomarkers, cognition, disability, response to treatment, etc. So here is an example of a spectrum. Here is a bipolar, Akiskal's bipolar spectrum. So bipolar 1, for example, which is at the right-hand part of the spectrum, has the greatest frequency of family history of bipolar disorder, has the earliest age of onset, has the highest frequency of psychosis, and the lowest prevalence of all other parts, which are ranked along these dimensions, either upward or downward. So it is like a very happy coincidence that these four dimensions here covary, and this is an example of a unidimensional spectrum. But we could have the case that these dimensions are orthogonal, that they do not covary, so we could also have a two-dimensional spectrum. Something I did here. So here is a brief history of how we conceptualize affective disorders in modern times, and this could be considered as a pendulum from Kreppelin's unity of the affective continuum to the unipolar bipolar dichotomy, and then back to unity, but through a spectrum concept. The concept, and in this spectrum concept part, we have some highlights, some milestones, the concept by Akiskal, proposed by Akiskal, the concept, the two-dimensional mood spectrum proposed by Angst, and more probabilistic approaches to soft bipolarity by more recent researchers. And I have here just Angst two-dimensional bipolar spectrum. This is a two-dimensional phenomenological bipolar spectrum. Angst has classified all affective states in two dimensions of severity and polarity. It's just a phenomenological spectrum. And the reason I'm presenting this is that I'm also going to talk about a two-dimensional spectrum. So I'm coming to mixed depression or depressive mixed states. And the question whether depressive mixed states should be considered part of the bipolar spectrum is crucial and has been the focus of extensive research. It has serious implications. Mixed depression has been regarded as the anchor point of major depression to bipolar disorder. And Kraepelin, of course, was one of the first to describe mixed states as a combination of highs and lows in mood, cognition, and psychomotor activity. And from the 6 kinds of mixed states he described, 2 refer to what we nowadays call mixed depression. Now, let's come to modern times. We have some of the earlier definitions. One of them was presented by Koukopoulos, who defined mixed depression as the coexistence of several symptoms of excitatory nature within a major depressive episode. One of these. And then several other researchers have elaborated on Koukopoulos' definition to provide a more categorical, let's say, definition of mixed depression. So mixed depression is the presence of at least 3, according to Benazzi, or even 1 or 2 of intradepressive hypomanic symptoms. And if we want to validate mixed depression as part of a bipolar spectrum, what do we have to do? We have to compare pairwise mixed depression with non-mixed depression and other putative parts of the bipolar spectrum, that is bipolar 1 and bipolar 2. We have to do all pairwise comparisons of all these putative components of the bipolar spectrum, comparisons on several clinical validators. So let's start from this first. Mixed depression versus pure depression, non-mixed depression. What does the literature tell us about that? And this has been done either in samples of only unipolar patients or mixed by unipolar and bipolar 2 samples. And these have been found to differ on several characteristics: age of onset, female prevalence, age, family history of bipolar disorder, lifetime suicidality, atypical features, psychotic frequency of psychotic depression, episode frequency, comorbidity rate, rapid cycling, temperament scores, frequency of borderline personality disorder, resistance to antidepressant and antidepressant-associated switch. And what about DSM-5? DSM-5 has changed the picture by presenting a new definition of mixed depression. First of all, it has proposed a mixed feature specifier and not a categorical mixed episode as previously, defined in both bipolar and unipolar patients. So it is broader than DSM-4's categorical diagnosis of mixed episodes, and it relies on the co-occurrence of at least 3, but non-overlapping intradepressive hypomanic symptoms. So irritability, psychomotor agitation, distractibility, and mood lability are excluded. However, this definition by DSM-5 is criticized as sacrificing validity for pragmatic concerns. That is, to prevent overdiagnosis of mixed state. Because the most prevalent mixed states in everyday clinical practice are actually characterized by these excluded symptoms. So this is the criticism against DSM-5's definition of mixed depression. And there are very few data available about the difference of patients with DSM-5 mixed depression versus DSM-5 pure, let's say, depression. That is, mixed depression is more frequent in bipolar patients. Psychotic features are more frequent. The greater depression severity, higher rate of comorbidities, higher rate of comorbid somatic diseases such as heart disease, AD-associated switch, and increased likelihood of remission with antidepressants. You remember before I told you that with the earlier definition it was a resistance to antidepressants. Here there is a study, this one by Perlis, which shows that mixed depression increases the likelihood of remission with antidepressants. So if we want to continue with the validation of mixed depression as part of a bipolar spectrum, the literature also compares bipolar and especially bipolar 2 with MDD. So here is a difference on several classical bipolar validators, and also bipolar 1 versus bipolar 2. Due to time, I'm going to skip this. So I'm coming to the second part. So as far less is known about the nosological status of MDD with lifetime mixed features, DSM-5 mixed features, what we did in Attikon General Hospital, our second department of psychiatry of the University of Athens, headed by Professor Douzenis, we compared patients, unipolar patients with lifetime mixed features with bipolar 1, bipolar 2, and patients with pure depression on 16 validators, including clinical characteristics, family history of bipolar and unipolar depression, temperament, and treatment, stabilizing treatment. Kostas Foudoulakis has helped me a lot with the analysis, and I thank him for that. So these were adult patients which were recruited at the Affective Disorders and Suicide Unit of Attikon Hospital, and they were followed up from 2010 for 5 years. The diagnosis was based on DSM-4 and 5 for lifetime mixed features. Almost 300 patients were included from the 4 categories, and most of them had been stabilized for at least 1 year on their medication, and their stabilizing maintenance regime was recorded. The 4 groups differed on sociodemographics only, on age. Pure depressed patients with pure depression were non-mixed, that is, depression, were significantly older, and there were somewhat more females in the bipolar 2 subgroup at the trend level. They did not differ, the groups did not differ in education. So, first of all, I'm going to present you some adjusted comparisons of the validators across groups. The groups were not matched on gender, age, and disease duration. So, we adjusted for this gender, age, and for gender validators also age of onset. And these adjusted comparisons were done with ANCOVA or non-parametric ANCOVA and generalized linear models for binary validators. The marginal means of these comparisons were produced and ranked from highest to lowest in order to check if the marginal means would be ranked on a bipolar diathesis gradient. That is, what we would expect if a bipolar spectrum was valid would be that all these validators would be ranked from bipolar 1, bipolar 2, mixed depression, pure depression. and we wanted to check if that would be correct. So for clinical features and psychiatric family history, 6 out of 8 variables were significant across groups, and as you see, for 4 of them, a bipolar diathesis gradient was actually followed. Mixed depression was right in the middle, bipolar 1, bipolar 2, mixed depression, pure depression. But for another 4, that is suicidality, psychiatric comorbidities, depressive episode frequency, and depressive family history, the peak was at the mixed depression group. So the bipolar diathesis gradient was not followed here, but there was a peak in the mixed depression group. And here is graphically this one. So we have the bipolar diathesis gradient for age of onset. We have the bipolar diathesis gradient for psychosis, for bipolar family history, but a peak at the mixed depression for comorbidity, the peak at the mixed depression group for depressive family history. We have the gradient, the bipolar gradient for hospitalizations, that is a proxy for severity, and we have the peak in the mixed depression group for suicidality and for depressive episode frequency. As regards temperament, only 2 temperaments were significant across groups, the hyperthymic temperament and the anxious temperament, and these ones followed the bipolar diathesis gradient, while for cyclothymic and the irritable temperaments, the peak was in the bipolar 2 and mixed depression groups. So this is graphically. We have the bipolar gradient for the hyperthymic temperament downward and the bipolar gradient upward for the anxious temperament, but we have the peak bipolar 2 and mixed depression group for the cyclothymic and the irritable temperaments. So at the next step, we did a discriminant function analysis. We wanted to see whether all these validators would predict category membership of the 4 diagnostic groups. So if you have 4 groups, the software analyzes 3 dimensions. Out of the 3 dimensions, 2 were significant. So we have a 2-dimensional surface here. We have the discriminant function 1, on which severity, bipolar family history, lifetime psychosis load, and early age of onset. So this is the classical bipolar, let's say, dimension, and we have a second dimension, a second discriminant function, on, which is most affected by psychiatric comorbidities, suicidalities, but also bipolar family history and severity, because suicide attempts leads to hospitalization, and very low scores on temperament and lifetime psychosis. And if we have these discriminant functions, we can plot the means of the we can plot the means of the groups on the 2 dimensions and have also distances calculated among the groups at the 2-dimensional surface. So what do we see here? We see bipolar 1 standing right at the end, far apart from the other 3. Mixed depression is in the middle of bipolar 2 and pure depression at equal distances. And what about classification? Classification was 59% overall. Classification was quite good for the 2 extreme parts, bipolar 1 and pure depression, but rather intermediate, mediocre for bipolar 2 and mixed depression. And when we also included treatment into our model, treatment with mood stabilizers, antipsychotics, and antidepressants, these were all significant across groups and very nicely ranked along a bipolar diathesis gradient, as we see here. So when these were also inserted into a new discriminant function analysis, the picture was quite similar, but the treatment variables were also included into the dimensions. And the two-dimensional surface was now like that. That is, mixed depression and bipolar 2 came very close together, closer than any other components of the spectrum. That is, when you include treatment, these two come very close together. This was treatment that stabilized patients for at least 1 year, right? And was recorded. So treatment of these two conditions should be similar. This is what this short distance tells us. And these two stand right in the middle between the other two. The structure is now more symmetrical. The classification is a bit improved to 66.6%. Again, the two extremes have a higher classification rate, and the two intermediate parts do better, but still not good well enough. So I'm not going to repeat the findings. I'm just moving to the limitations. The limitations are that, of course, lifetime mixed features in MDD patients were retrospectively recalled. We did not have records of lifetime mixed features in bipolar patients, and this would be very interesting, but then we would have 6 or 8 groups, so this would be very cumbersome to analyze. And also, lifetime mixed features in bipolar patients are actually quite frequent. So we could have percentages something like 90% or so. This would have no point. And also, the required follow-up time for stabilization was kept to 1 year due to feasibility reasons, but this may be inadequate in terms of bipolar disorder therapeutics. So my overall conclusion is that we remodeled for the first time the bipolar spectrum on a two-dimensional surface on the basis of classical external validators, clinical, family history, temperament, and treatment. However, the predictive validity, or better, the discriminatory ability of this set of variables, which was a clinical set of variables and treatment-related variables, was mediocre for intermediate members of the spectrum. So validation should be enriched with additional variables such as genetic data, biomarkers, imaging, neurocognitive, and psychophysiological data, some of which we do have, and potentially explore a higher dimensionality of the spectrum. Thank you very much.
Are there any questions from the audience? Thank you, Dr. Ferentinos. So I think we can wrap this thing up and make space for the next presenters. Thank you very much.
So, good morning. Thank you for being here. And I'd like to welcome you in our round table entitled Facts and Myths of Sexuality. And first of all, please accept the apologies of Philippos Kouniakis, who had a personal last-minute problem and couldn't manage to be here. So we will start with the second presentation, presented by Konstantinos Randis, and the title is The Neurobiological Basis of Sexuality and Its Dysfunctions.
Good morning, ladies and gentlemen, Mr. President. The topic is huge, and thankfully Mr. Kouniakis couldn't come, so more time for me. But still, I have a feeling that I will be giving you just a summary of the summary, and I will start right ahead. My presentation will be based on those two books from the European and the International Society of Sexual Medicine, plus some more recent publications. And I will start with a brief reference to the phases of sexual response, as described by Masters and Johnson in 1966, excitement, plateau, orgasm and resolution, or by Helen Kaplan, desire, excitement, orgasm and resolution. Starting with desire, the mechanism of desire is described in this complex figure with many brain regions interacting with each other with excitatory or inhibitory neurotransmitters, plus some more hormones. I'll try to explain this in words. Cerebral regions in desire, the prefrontal lobe with the inhibitory role, sensory and limbic cortices activated by sexual stimuli, and the hypothalamus, mainly with the ventromedial nucleus and the medial preoptic area, different activation in both sexes. Neurotransmitters, excitatory, dopamine, norepinephrine, melanocortins, oxytocin, serotonin, and the inhibitory, prolactin, GABA, serotonin, etc. Hormones. Testosterone facilitates desire in both sexes, estrogens in female. However, progesterone has some inhibitory effect. Prolactin has inhibitory effects, acting directly or indirectly on libido. Orexin and leptin by modulating the estrous cycle and enhancing dopaminergic activity. So desire is regulated by a hormonally responsive neural network, as you can see in the picture. Disorders of desire. Male hypoactive sexual desire disorder. Serotonin 1B and 1C receptor activation has an inhibitory effect. Low dopamine increases serotoninergic activity. Mild and severe hypogonadism can cause hypoactive disorder. And severe hyperprolactinemia, which induces hypogonadism and high serotoninergic activity. Acromegaly can cause hypogonadism, high PRL or PRL-like effects. Hypothyroidism inhibits sexual desire directly or via PRL rise. And 5-alpha reductase inhibition, which lowers the levels of circulating neurosteroids. In females, low desire can be caused by cerebral damage in cerebral structures like the HPA axis, or increased activation of frontal gyrus and the putamen, or decreased activation of endorenal cortex. Low estrogens can cause atrophy, dyspareunia, depression, etc. And testosterone, which seems to have a more complex role in female responsiveness. Hyperactive sexual disorder could be due to lesions that cause the disinhibited behavior or affective dysregulation, increased androgens or testosterone receptors, serotonin, as it could be described as an OCD-like behavior, or dopamine, as there is some response to dopaminergic medication. While sexual aversion disorder is more like a fight-or-flight response with an increase of noradrenergic activity causing a reduction of sex hormones. Next phase, arousal or erection. Here, there are spinal pathways involved, afferent, efferent, lumbosacral, somatomotor, with associated neurotransmitters, as you can see. Afferent neurons bring stimuli to the brain. Parasympathetic stimulation and sympathetic inhibition cause erection and vaginal lubrication. Female genitalia are especially innervated by all these neurotransmitters, while penile muscles are innervated by the somotor neurons. This is a sketch of the innervation of the male genitalia and one of the female. Cerebral regions. In male erection, temporal, frontal, insula, etc., involved in stimuli processing, and the hypothalamus involved in response. Same in women, more or less, depending on the study. Here I have some pictures of functional imaging during arousal. The regions that we described before, depending also on the stimuli. In further detail, hippocampus and the amygdala are the two main limbic regions involved. MPOA and the VMN contain cells with hormones, and the different INIH product expression could also play a role. Sympathetic, parasympathetic, and somatic pathways of the brain regulate neurotransmitter activity, with oxytocin and vasopressin being the primary peptide in female and male circuitry, respectively. Neurotransmitters, proerectile like dopamine, noradrenaline, acetylcholine, etc., anti-erectile, some other serotonergic, A2 noradrenaline, GABA, etc., acting on central or peripheral receptors, directly or indirectly. Hormones, testosterone and the DHEA have proerectile action in men, regulating the neurotransmission in CNS, or by acting on the peripheral motor neurons and blood vessels. Estrogens attenuate arousal in women, while either by maintaining healthy genitals or by activating estrogen receptors in the CNS. Oxytocin has central proerectile and peripheral anti-erectile action. Prolactin inhibits dopaminergic activity in the hypothalamus and affects the penile smooth muscles. Melanocortins increase sexual receptiveness via MC3 and MC4 receptors, and the thyroid hormone receptors have been found in endothelial and smooth muscle cells of the genitals. GH has anti-erectile effect by causing peripheral vasodilation and the relaxation of the smooth muscles. LH regulates testosterone secretion, and melatonin facilitates desire and arousals, at least that's what we have found in animal models. Dysfunctions, starting with male. Hypogonadism is found more often in patients with ED, associated with increased LH levels. Low levels of prostaglandin have been detected in men with ED and severe T deficiency. Severe hyperprolactinemia was associated with ED, and hypoprolactinemia is also significantly higher in patients with ED. Acromegaly is associated with impotence, either by direct effect on penile relaxation or overproduction of GH insulin-like growth factor, or via mass effect on gonadotropic cells. Hypothyroidism and overt hyperthyroidism have also been associated with erectile dysfunction. In women, estrogen deficiency is associated with vaginal dryness and reduced sensitivity, but if sufficiently stimulated, the female can be aroused. Thyroid diseases may double the incidence of arousal disorder in premenopausal women compared to controls. Persistent arousal disorder may be a result of hypersensibility or pelvic congestion. In orgasm, the same afferent and spinothalamic pathways as in arousal. Afferent pathways bring stimuli to spinal centers. Sympathetic neurons cause emission in men and contractions in women. Somatic neurons are responsible for seminal expansion, and the spinothalamic neurons coordinate all of the above. All these are summarized in this picture, at least for the male, the peripheral centers. Cerebral regions involved during orgasm, blood flow is decreased in prefrontal and orbitofrontal cortices, decreased in temporal, amygdala, and the other parts of the limbic system, and increased in primary motor and somatosensory and cerebellum. Other regions that play their part in the hypothalamus, the brainstem, and their according neurotransmitters. Talking about neurotransmitters, serotonin seems to have a complex role, with presynaptic 1A receptors being pro-ejaculatory and 2C anti-ejaculatory, and alpha-1 adrenergic neurons bring autonomous impulses to the genitalia. Concerning hormones, testosterone facilitates ejaculation in men with central and peripheral action, while estrogen in women may not be so effective, as sufficient stimulation can result in orgasm even in women with low levels. Oxytocin promotes semen emission and penile and clitoral detumescence, whereas thyroid hormones have an unknown mechanism of action. Possibly they regulate other neurotransmitters or hormones, or have their own receptors in human testes, which should mean they play some part. Let's take a quick look on the disorders, starting with premature ejaculation, which could be due to a sympathetic hyperstimulation, shorter spinal reflexes, hypersensitivity of the genital skin, or a general hypertonic state with increased oxytocin and serotonin activity, and the increased activity in the TRP ion receptors in genital skin. Central serotoninergic inhibition, hyposensitivity of 2C and hypersensitivity of 1A receptors, or polymorphism in serotonin transporters or 1A receptors, and the polymorphisms in dopamine transporters have been accused, let's say. High testosterone levels, hyperthyroidism may alter adrenergic and serotonergic activity and decrease SHGB, and finally higher leptin levels have been found in patients with premature ejaculation. In delayed ejaculation, desensitization of the serotonin 1A receptors on oxytocin neurons and their activity of TRP ion receptors. Low testosterone may inhibit spinal reflexes. Hyperprolactinemia usually associated with erectile dysfunction. And hypothyroidism increases serotonin in brainstem. In these two graphs, we can see the association between testosterone TSH and ejaculation latency time. High testosterone, lower latency. Lower TSH, lower latency. Finally, anorgasmic anhedonia could be due to sacral and cephalic lesions in both sexes. I think we have time to speak about some other disorders that are not classified above, which could be pain disorders due to lack of estrogen or a fight or flight reaction to stress, as penetration could be perceived as stressful. Pelvic pain disorder due to neurogenic inflammation, hypersensitivity to stimuli, or hyperactivation of brain regions associated with pain. Gender identity disorders. Here we have found differences in brain structure. For example, BNST and the amygdala have the same structure in female transsexuals as in straight women, and the opposite to the other sexes. And atypical levels of sex hormones have been found in utero. In paraphilias, in pedophilia, the etiology is unknown, but we have found defects in amygdala, the superior front occipital, and the right arcuate fasciculi, and the HPA axis. While in other paraphilias, there is the theory of frontal, temporal, or septal lesions. Some other studies have found dilation of the ventricular temporal horns, especially right to the right, possibly associated with temporal atrophy. Neurotransmitters, serotonin, as it could be described as an OCD-like behavior, and dopamine seem to play the role too. And I will finish my presentation with this table, which I think summarizes all that we said before on neurotransmitters and hormones in the different stages of the sexual response. Thank you for your time.
Thank you, Konstantinos. Are there any questions for this presentation? Yes?
I would be interested to know about the neurobiological basis of dry ejaculation.
The dry ejaculation.
Yes.
Dry ejaculation, from what I found, is mostly pharmacological.
If the patient is on no medications at all.
No medication on dry ejaculation?
Yes.
I don't know. I haven't found anything.
Thank you.
Thank you. Any other question? Thank you, Konstantinos. So, well, our next speaker is Fotini Fereninou, and her presentation has the title Evidence-Based Psychotherapy of Sexual Dysfunctions.
Thank you. Good morning, everybody, and thank you for being here today. And a special thanks to Professor Foudoullakis for inviting me in this interesting congress. Psychological interventions are one therapeutic step of when we are facing a sexual problem. It's not an obligatory step. Not every patient is going to need a psychological intervention. We begin with a basic assessment, the basic evaluation, and maybe the patient will need some kind of psychological treatment. What all patients need is a sexual counseling, which is going to be provided by the sexual medicine physician. And this will include giving time to the patient who may have never talked about his problem before to anyone, explain how sexual physiology works, how sexual function works, and maybe break a lot of myths which are evident in this field, identify the risk factors, the biological factors, the medical factors that may be responsible, and then personalized therapy, which may include psychological interventions. So, the approach of the sexual medicine expert should be holistic, taking into account the potency of drugs, the couple's dynamics, and providing specific sexual counseling. What we should have in mind is that sexual function is a very different function for men and women, and we're not talking about the biological components. We're talking about the help-seeking behavior, which is very different between males and females. Men, specifically, tend to take sexual health for granted, and they don't have a lot of information regarding health issues. They usually attribute the sexual problems to medical or pharmacological conditions, not considering psychological factors as really important. And the main priority seems to be performance, their performance. While women are usually more eager to seek help from a sex therapist, from their gynecology, from the talking they have with other women. They consider psychological and relationship issues as important. They accept that their partner may have different needs from them. And they tend to have as a priority psychological components like sexual feelings. So, although the fact that there are a lot of differences between the genders and between the way men and women work in this part of function, the objectives of the therapy should be the same in order for it to succeed. So we should have in mind that the restoration of reliable sexual function regarding the age of our patient is an important aim. A general improvement of the sexual satisfaction, the psychological well-being, which are objective components for every person, the improvement in the communication of the couple, the enhancement of their intimacy, and the improvement of the quality of life. So when we decide, in cooperation with the patient or the couple, that sex therapy is indicated, alone or together with other kinds of interventions, medical or lifestyle interventions, the question is, which is the appropriate type of therapy? We're going to talk a little bit about the historical background on that field. The first psychological approach for many, many years on sexual problems was psychoanalytic. As you may know, it was for a lot of psychological problems. Freud was saying that the origin of sexual problems was from unresolved conflicts of childhood or problematic attachment to the parent. The treatment was lengthy and was trying mainly to unmask and resolve the unconscious intrapsychic conflicts. In the 1970s, a different approach was introduced from this couple, Masters and Johnson. It was mentioned before. They had a more behavioral approach to sexual problems. This included a brief problem-focused therapy with sexual exercises and had as an aim the experience of positive sexual feelings through positive sexual experiences. It included a stay of 2 to 3 weeks in a clinic. The couple had to stay there for 2 to 3 consecutive weeks, and they would go through exercises every day to improve their sexual life. New sex therapy was introduced by Helen Kaplan, this lady, in the late 1970s, who used a combination of approaches, actually. And then Barlow, in 1986, he introduced a more cognitive model where he has shown that the distracting conditions may be the etiology of negative emotions and may have a negative impact on sexual function. In the 1980s, the role of the relationship was highlighted. 20 years before, PD5 inhibitors were introduced as a therapy for erectile dysfunction, and the combination, the combined approach was then introduced in sexual medicine. So the combined approach, the combined biopsychosocial model that is suggested nowadays is a synthesis of all types of interventions, having as the final goal a lasting and satisfying sexual function. Besides, the importance of biological, psychological, and relationship factors in the formation of a sexual problem are known, taking into account their role as predisposing, precipitating, and maintaining factors. So, psychosexual therapy usually employs principles from other therapeutic modalities, but focuses on the treatment of the sexual problem. Nevertheless, it's not a cookbook. It cannot be a cookbook. It cannot use a single protocol of interventions for every case, since it depends on a variety of factors, such as the patient and the personal traits and characteristics of the patient, the couple, if there is a partner, the therapist, chance events, such as a new relationship which may pop up throughout the therapy, the motivation of the patient, contextual factors, which may be family or financial problems, and the timing the problem appears throughout the lifespan. It's quite different for a problem to appear during the menopause or for a problem to appear at 20 years of age of a young man. So going in more detail into the several psychotherapeutic approaches that are available today, psychoanalysis, although expensive and lengthy, may help sometimes some individuals or couples to correct their maladaptive sexual behaviors and therefore complete successfully some behavioral tasks. Moreover, there are psychodynamic terms which can be worked out through sex therapy and can help the outcome in combination usually to other interventions. But sexual problems, as I mentioned before, are problems and dysfunctions more often of the couple and less often of an individual alone. Therefore, the systemic approach seems to fit well to sexuality. A sexual problem more often belongs to a larger context than the bodily functions of organs, and more often it is part of a relationship. Therefore, the interactions in the couple, which happens through the several ways of communication, is of great importance. The relationship follows 3 steps. The first step, that's the falling in love period. The second period, that's the experience of the differences period, when the couple understands that maybe they're not soulmates. And the bridging the differences period, which the couple tries to come together. Therefore, it's important for us to know at which of the 3 stages a sexual problem arises. Additionally, marriage nowadays and its principles have changed to a working together equivalent relationship, where the solution for all the problems in life usually comes from a working together condition. And in addition, sexual problems also will be solved through a working together condition. On the other hand, the sexual problem may have a different role in every couple. Sometimes its maintenance is important for the relationship, which needs the sexual problem, or the relationship may be so problematic that causes the sexual problem, or at least boycotts the available solutions. Finally, while practicing couple therapy, we should keep in mind that sexuality may have a different meaning for its partner, may have a different importance for its partner. We have to do with 2 different individuals, and the therapist should focus on bridging the gap, improving the couple communication, and creating realistic expectations and a realistic intimacy environment. CBT. CBT is the most effective psychological treatment for a variety of psychological problems today. Studies on the psychological factors that play a role on sexual dysfunctions have underlined how cognitions, followed by certain behaviors, can produce sexual problems. And when we intervene within these cognitions, we can change the behaviors and help therapeutically. The CBT strategy, as you may already know, except for the common parts of history-taking and diagnosis with a focus on predisposing, precipitating, and maintenance factors, is based on certain protocols, which are behavioral assignments and cognitive restructuring. The behavioral assignments that we use in sex therapy are sensate focus, which is usually used in situations where performance anxiety is the core etiology of the sexual problem, affecting desire and arousal. Systemic desensitization, which is usually applied in cases where a phobic response to a sexual stimulus is evident, and it starts from relaxation skills, followed by gradual exposure to the distressing condition. The stop-start technique and squeeze also technique are assignments that gradually help the patient learn to control his ejaculation. They're used for premature ejaculation problems. Guided stimulation techniques are used for delayed ejaculation problems and help the patient identify effective physical stimulation, and with the help of fantasies increase the subjective arousal he feels. Directed masturbation is frequently used in women with orgasmic problems, while mindfulness techniques are recently used for a variety of problems, and I'm going to refer to them later on. Cognitive restructuring consists of the identification of the cognitive system and the cognitive restructuring techniques. The cognitive system includes the automatic thoughts, which are thoughts or images that pop up involuntarily to the individual and relate to emotional and behavioral responses, and the cognitive schemas, which is something more in depth, which is something behind the thoughts and beliefs, and are structures responsible for the meaning individuals assign to events. For example, the schema of incompetence is often activated in men with erectile dysfunction. An example of a cognitive structure is this structure here. We call it in Greek the 4 sigma, from the word skepsis, συναισθήματα, συμπεριφορά, σωματικά συμπτώματα. For example, a man's thought before starting sexual activity may be, I will not get an erection. This will have as a consequence these feelings of anxiety or of fear. And the behavior that may follow is that the man will be looking at his erection, will be observing how the erection is evolving, having as a final problem the loss of the rigidity of the erection, and then the man will confirm the initial thought. Cognitive restructuring tries to break this cycle through several techniques which aim to change the initial thoughts with alternative positive thoughts, which will be followed by positive feelings and alternative behaviors. Mindfulness techniques have only recently been applied to sex therapy and to psychotherapy in general, with promising results. John Kabat-Zinn, that guy over there, who is the one who initiated mindfulness, says that when you see and feel the sensations you're experiencing as sensations, as pure sensations, you may see that all the thoughts about the sensations are useless. So you should only focus to the sensation. So mindfulness teaches us how to have a non-judgmental attention into the moment, to bring our awareness to our body and to the sexual sensations in our situation, without thinking about the past or future, but even if such negative thoughts come, accept that they are there, try to neglect them, and refocus on the sexual sensation. Is a type of meditation technique, actually. As you may have already realized, combination therapy for delivering care for sexual dysfunctions is becoming the gold standard, based on the biopsychosocial model. and to the fact that biological and psychological factors are additive and interactive. While combined therapy has been observed to have enhanced efficacy, treatment and relationship satisfaction, decreased discontinuation of pharmacological treatments, and improved adaptation to the sexual problem. But the problem is that there is still no evidence-based model or protocol for combination therapy up to date, and its practice includes some unanswered questions, such as who will deliver it? Will it be a nurse? Will it be a psychologist, a psychiatrist? And how are the treatment components going to be applied, stepwisely or at the same time? There seems to be a difficulty in matching evidence-based research requirements to psychotherapy, although we all know that this is the only way to check how efficient it is. One reason is that the evaluation of success in clinical trials may differ from psychotherapy. So it may be difficult to have randomized controlled trials which will compare psychotherapy to pharmacotherapy. For instance, clinical trials with drugs may have as a primary outcome of interest the frequency of sexual encounters, while psychotherapy may value more qualitative characteristics, such as sexual satisfaction. Other difficulties include the placebo effects, extra-therapeutic factors, such as patient motivations, chance events, the relationship between the therapist and the patient, as well as the type and protocol that the psychotherapist will follow. As if all these problems were not enough, outcome studies on psychosexual therapy are scarce, since funding is rare and limited, because pharmaceutical companies have no incentive to fund such studies, because they take also a lot of time to be completed. But we have some sort of evidence on the field concerning female sexual dysfunctions. Most studies have a level of evidence 2, 3, and 4. For desire disorders and arousal disorders, CBT, both, or also combined with behavioral techniques such as sensate focus exercises and mindfulness interventions, have positive results. Again, behavioral interventions such as masturbation exercises or in combination with CBT are useful for orgasmic disorders. Concerning pain disorders in women, desensitization exercises and CBT have shown positive outcome, while relaxation techniques are helpful for vaginismus. There is a level 3, 4, and 5 of evidence for the relationship between sexual and relationship functioning, and therefore the literature suggests better outcome, better long-term outcome for men and women when relationship issues are addressed, treated, resolved. Regarding men's sexual dysfunctions, the level of evidence is again 2, 3, and 4. For ED, the combination of behavioral exercises such as sensate focus and masturbation exercises, as well as CBT and psychodynamic interventions, have been found to lead to positive outcome. For premature ejaculation, behavioral assignments, especially stop-start technique, is the one we use, as well as CBT interventions. Literature is pretty scarce regarding delayed ejaculation, but psychological approaches including sex education or focused stimulation, which include increased and more genitally focused stimulation, could be useful. And concerning hypoactive sexual desire disorders in men, there is a positive outcome research for psychosexual therapy. Finally, again, the relationship factor plays an important role also for men's sexual function. Concluding and having in mind all the psychotherapeutic methods available today, We have to have as a take-home message that psychosexual therapy is not a cookbook. We have to take to have in our mind all the important variables that may play a role. The problem, there are different guidelines for every problem. The patient traits and characteristics, biological, psychological, does she have a psychological thought to go through a psychotherapy? The partner, the availability of a partner, we will work differently when somebody comes to us as an individual and differently when he is accompanied by a partner. The type of the relationship, we will work differently in a marriage and in a relationship of a young couple, which may be short-term, as well as additional factors such as the kind of therapy the therapist is trained well to practice, the financial state of the patient, which may be a limitation for a long-term therapy, as well as family or occupational issues which may pop up throughout therapy. Thank you all for your attention.
Thank you very much, Fotini, for these presentations. Are there any questions? Yes, please.
Thank you very much. Christos Leonis from the University of Crete. I'm not a psychiatrist. I'm involved in mental health disorders, management in primary care. I enjoyed very much your presentation. In the last year, New Zealand and Australian physicians that's producing the guidelines, evidence-based guideline, and giving more emphasis of bio-socio-psychological model, and just giving more emphasis in the psychosocial treatment on mindfulness and mindful-related techniques, and not only just for sexual disorders, but in generally, and recommended among those issues should be the primary care providers should be exposed. And I'm just asking, in Greece at the moment, is how, to what extent the mindfulness or mindful-related techniques have been in use, either in sexual disorders or in general in mood disorders, and if it's any center, in any training center in spreading more, since I'm certain times I'm listening, but not having accurate information where exactly such training should be provided. Thank you.
Thank you for your remark. It's actually a very interesting field, this new intervention of mindfulness. In Greece, we have absolutely no center that can provide therapies through mindfulness techniques. There are some psychologists who have been trained in the UK, I think. I was in contact with them through a CBT Congress last year. But they're still trying to make a more stratified procedure in order to teach other psychotherapists on the field. It seems, though, to borrow a lot of techniques from what we say in sexual medicine, sensate focus, which is a focus on the sensation, on what we receive as sexual sensations at that time, and try not to think. This is, I think, the whole idea. But no, absolutely no, it's a very, very first step thing.
Thank you for the excellent presentation. And my question is, how frequent you see couples who live with this problem of having no sex at all, whether it's the husband or the wife or the male or female is the cause, yet they live together. And the reason I'm asking, because I've seen two couples in my practice. In one of them, they were married for 20 years. And the wife was suffering with depression, and she had some gynecological problem. I referred her to the gynecologist, and to my surprise, the answer was that she was virgin. They had no sex at all. They were living together. They looked happy on the surface. The other couple is a woman who came in with her fourth husband to see me for a problem because she had fear of having sex, and she got 3 divorces, and that was the fourth husband, yet she was still virgin.
Thank you. Your question is really, really interesting. You are talking about unconsummated marriage. That's how we call it. And this is quite a cultural, it has some cultural factors that are playing a role. In some countries it's more often where people don't feel so secure to go and ask for help. In Greece, it's not that often from our experience in the outpatient clinics, but when it happens, these couples come for help because they want to have children. And if you don't have sex, you cannot have children. So they usually come with that as a motive. And usually the etiology is vaginismus problems or sexual aversion from the women. This is a very often etiology because of a sexual trauma or because of other psychological reasons. But it may also be erectile dysfunction from the man because he had one incident of failure, and since then he doesn't want to try again. He's afraid to try again. But it is, though, a very interesting case, the unconsummated marriage. I think in the Arabic countries, it's quite often we see high prevalence of this because they are a little bit more reluctant to go to the sexual medicine physician there.
Yeah, the first case of 20 years of marriage was in Ireland, in Irish culture. The second one was in Arab culture.
Thank you, Fotini. Now we'll present the last talk of our session, evidence-based pharmacotherapy. Or the lack of pharmacotherapy. So, good morning. First of all, I have no conflict of interest to declare, and this is a brief outline of my presentation: treatment of sexual dysfunction caused by SSRIs, sexual dysfunction in men, focusing on dapoxetine, and sexual dysfunction in women, focusing on flibanserin, the newly approved drugs. First of all, sexual dysfunction caused by SSRIs. We already know that SSRIs can reduce libido in women and men, disrupt arousal, cause anorgasmia in women, and increase ejaculation latency in men. And the estimated incidence of these dysfunctions ranges from 15 to 80%, so it's about 50% of two of our patients suffers from sexual dysfunction due to SSRIs, and the frequency of these sexual side effects may vary among the different SSRIs. So, although it's not known exactly how SSRIs impair sexual functioning, the symptoms appear to be dose-dependent, and also genetic polymorphisms may be involved. According to current data, the first-line treatment for these dysfunctions is to wait. Waiting 2 to 8 weeks for remission of sexual impairment, and that may work best for patients with mild sexual dysfunction. And if impairment persists, we should decrease the dose. Second-line treatment is to switch to a non-SSRI antidepressant or a different SSRI. And the last option is to use a second drug to offset the adverse effects. So what about switching? For depressed patients with substantial benefit from SSRI therapy, but severe sexual dysfunction, or with modest benefit from the SSRIs and moderate dysfunction, it is suggested, and that's a grade 2B recommendation, so not very strong recommendation based on moderate quality of data. So it is suggested to switch rather to augment, rather to add on SSRI. And it is suggested to switch to a non-SSRI, especially bupropion. We could use a different SSRI, but I think the results will be not different, although the different SSRIs have different properties regarding these sexual side effects. And there are no head-to-head trials that have compared these strategies. What's the data about bupropion? There are several randomized trials that have established that the sexual dysfunction occurs less often with bupropion than SSRIs. And there is a great network meta-analysis of 37 randomized trials by Reich and Fader with about 14,000 patients that found that the incidence of sexual dysfunction was less with bupropion than escitalopram, paroxetine, or sertraline. Other non-SSRIs, if sexual dysfunction persists, despite the switching to bupropion, we have to switch to mirtazapine. And there is also a network meta-analysis by Watanabe with about 1,000 patients suggesting switching to mirtazapine. Concerning different SSRIs, the data is of low quality, although it is stated that incidence of dysfunction may possibly be greater with escitalopram or paroxetine than the other SSRIs. Add-on therapy, the option to add on a second drug to the SSRIs in order to ameliorate the impairment. There are no head-to-head trials that have compared PDE5 inhibitors and bupropion. Those are the two options, and there is a meta-analysis of 3 trials versus placebo concerning bupropion, suggesting that sexual functioning improved more with bupropion, and thus it could be an option. The drug we have to add to the SSRIs in order to resolve the impairment. But the suggestion, the recommendation, a grade 1B recommendation, that means a strong recommendation, is for men with erectile dysfunction, adjunctive treatment with PDE5 inhibitors rather than bupropion. A grade 2C recommendation for women with sexual dysfunction is to add on bupropion at higher doses, 300 milligram, in order to achieve our goal. And another option, but with weak evidence, is to add on buspirone. Treatment of male sexual dysfunction. So As mentioned before, the three most common male sexual dysfunctions are decreased libido, erectile dysfunction, and ejaculatory dysfunction. And one or more conditions can coexist in an individual. So the inability to achieve or to maintain an erection sufficient for satisfactory sexual intercourse is affecting up to 1/3 of adult men. So it's a high prevalent condition. And concerning decreased libido, the estimated prevalence is about 5 to 10%. But depending on the cause, we can treat. We know that the most common causes, as mentioned before, for decreased libido are psychological or partner interactions, low testosterone, which is treated with testosterone replacement therapy, other sexual problems such as erectile dysfunction, premature ejaculation, or Peyronie's disease, and treatment of these conditions sometimes restores libido. Medications, most commonly SSRIs, could lead to decreased libido, alcohol, and also the chronic use of opioids, which results in low testosterone levels, is a common cause of decreased libido. Konstantinos mentioned before the etiologies of erectile dysfunction. You can notice that erectile dysfunction is classified as organic, psychogenic, or mixed. And here are the most common causes, the etiologies of erectile dysfunction: vascular, cardiovascular disease or hypertension or diabetes, neurological diseases such as Parkinson or Alzheimer's disease, hormonal, hyperprolactinemia, hypothyroidism, drug-induced erectile dysfunction caused by antidepressants, antihypertensives, antipsychotics, or recreational drugs, and also psychogenic reasons. According to the evidence, and there is a strong recommendation, a grade 1A recommendation, that means a strong recommendation based on high-quality data, first-line treatment of erectile dysfunction are PDE5 inhibitors like sildenafil, vardenafil, tadalafil, and avanafil, because of their efficacy, the easy of use, the favorable side effect profile, and all these drugs seems to be equally effective. But tadalafil has a longer duration of action, and avanafil has a more rapid onset. What's the mechanism of action of PDE5 inhibitors? They act by increasing cyclic GMP levels. They are competitive inhibitors of the PDE5 enzyme. And as a result, they increase both the number and the duration of erections in men with erectile dysfunction. We already know that stimulation is needed for the erection, and here you can, in this figure, you can notice that the duration of action is similar for sildenafil, vardenafil, and avanafil, 4 hours, but much longer for tadalafil. And tadalafil can be used daily, in low doses daily. The other three PDE5 inhibitors are used on demand. Ejaculation disorders, premature ejaculation, can be defined as ejaculatory latency time of about a minute or less. And mainstays of therapy are SSRIs, grade 2B recommendation, and also topical anesthetics like aerosolized lidocaine, prilocaine spray, which can be used 5 minutes before the intercourse. Concerning the SSRIs as a first-line treatment for premature ejaculation, paroxetine may be the most effective drug. 9-minute ejaculation delay over baseline was observed in a meta-analysis published by Waldinger. We know that this effect, the full effect of the SSRIs, needs about 2 to 3 weeks of therapy, and a newly approved drug and interesting drug is daboxetine, which I will discuss in my next slide. Second-line therapy is clomipramine, and there are some studies and 2 meta-analyses of tramadol, on-demand use, 50 milligram, 1 to 2 hours pro sex, but side effects of the drug, I think that the drug cannot be recommended because of the side effects. So, some data about daboxetine. Daboxetine is a rapidly absorbed, short-acting SSRI used for on-demand treatment of premature ejaculation. It is licensed for this indication in many countries. Some pharmacological facts: time to peak concentration is about 1 to 2 hours, and the half-life elimination time is about 1.5 hours. And the drug should be received 1 to 3 hours before the sexual intercourse, and no more than once in 24 hours. The primary outcome in most of the trials of daboxetine was intravaginal ejaculatory latency time measured by the partner using a stopwatch. And it was observed that the mean latency time increased from an average of about a minute at baseline to 1.75 minutes with placebo and 2.8 minutes with daboxetine. And also a comparative trial was published in which paroxetine was more effective than daboxetine, although it was unclear when treatment was taken in relation to the sexual intercourse, and this may have affected the efficacy. The adverse effects of daboxetine are dose-related. Some of these are nausea, headache, or diarrhea, and also sexual adverse effects were noticed, like erectile dysfunction or abnormal ejaculation, and also postural hypotension. And a very significant interaction of daboxetine is that it's a major substrate of CYP2D6 and CYP3A4 enzyme of the liver. So the drug is contraindicated with SSRIs, SNRIs, or herbal products with serotonergic effects like St. John's wort or lithium, because in co-administration with strong CYP3A4 inhibitors like ketoconazole or clarithromycin, the concentration of the drug is increased. The same result is produced also by co-administration with strong CYP2D6 inhibitors like fluoxetine and paroxetine and bupropion. That's why the use is contraindicated with these drugs. And also, the daboxetine is contraindicated in patients with heart problems like heart failure or conduction abnormalities. So concluding, although daboxetine prolongs intravaginal latency time before ejaculation, the improvements seem modest, and placebo effect was apparent in most of the studies. And the benefits and adverse effects of the paroxetine treatment should be reviewed in about 4 weeks or 6 doses of treatment. And the last part is sexual dysfunction in women. In the United States, about 12% of the women report distressing sexual problems like lack of sexual desire or impaired arousal or inability to achieve orgasm or pain with sexual activity. And it was already mentioned that female sexual dysfunction is multifactorial. So treatment must be tailored to the sexual dysfunction diagnosis and the underlying physical and psychological factors. And there are some challenges to evaluate these treatments because there are inconsistent measures to assess efficacy. Most of the studies of sexual dysfunction treatment use validated questionnaires and different questions and different scales. And that's why it's difficult to compare data between studies and between treatments, not only between pharmacological treatments, but also between pharmacological and psychological treatments. So there are some non-pharmacological therapies. That's not the point of my presentation, but there was an interesting device here, this eros-clitoral therapy device, approved by the FDA for female sexual dysfunction, but I think it's not longer on the market, and I don't really know how it works exactly, so don't ask me about that. Hormone therapy, as mentioned before, depending on the underlying biological basis, we could use androgens or estrogens, and a very interesting drug is ospemifene, a selective estrogen receptor modulator, the first oral treatment approved by the FDA for the treatment of dyspareunia associated with vulvovaginal atrophy. Further, tibolone, a synthetic steroid with estrogenic and androgenic properties, was approved in some countries, not approved by the FDA, due to concerns about risk, especially risk of breast cancer and stroke, but it's still used by postmenopausal women in Europe and some other countries. PDE5 inhibitors have not proven successful in women, so there are some psychotropic agents that could be used, like bupropion that I mentioned before. There are 2 positive RCTs, placebo RCTs, of premenopausal women with hypoactive sexual desire disorder, which were non-depressed, and they reported increased sexual pleasure, arousal, and orgasm with bupropion. And flibanserin is the first and currently only drug approved by the FDA for female sexual dysfunction with the indication hypoactive sexual desire disorder, meaning premenopausal women with low sexual desire with associated distress. Flibanserin is a centrally acting mixed 5-HT1A agonist and 5-HT2A antagonist, and it also has some moderate antagonistic activity at D4 receptors, leading in decreases in serotonin, increases in dopamine, and norepinephrine in certain brain regions. Data about the efficacy of the drug showed that daily use results in modest increases in the frequency of sexually satisfying events and sexual desire in women with low sexual desire associated with distress. And we know that the onset of efficacy with flibanserin starts about at 4 weeks of treatment. The brand name of the drug is RD or something like that. So the pre-marketing trials, in the pre-marketing trials, fatigue, dizziness, nausea, headache, sedation, hypotension-related events, and syncope were noticed. And also, a minus of those trials was that women on antidepressants and antiestrogens were excluded from the randomized trials. And of course, the safety of the drug in pregnancy is not known. What's interesting is that in post-marketing meta-analysis of the trial, which included 5 published and 3 unpublished studies involving almost 6,000 women, but with a very low-graded quality of evidence, it was noticed that concerning safety, the risk of dizziness and sleepiness was 4 times higher in women receiving the drug and 2 times higher nausea. And also, there was an increased risk of fatigue by more than half of the women. And concerning efficacy, 2.5 satisfying sexual events per month before entering the study, flibanserin added only 1/2 additional satisfying sexual event per month. So the drug was approved, but very, very quickly it received a US box warning. It's contraindicated with alcohol, with strong or moderate CYP3A4 inhibitors like ketoconazole, fluconazole, or clarithromycin. And it's also contraindicated in patients with hepatic impairment. And also there are some limitations. Flibanserin is not indicated for the treatment of hypoactive sexual desire disorder in postmenopausal women or to enhance sexual performance. And further limitation is the cost of the drug. It costs about $1,000 per box. So the FDA requires that prescribers complete an internet training to be certified and to counsel patients, and also the dispensing pharmacies must be certified. And a small story behind this approval, flibanserin was initially studied as a potential antidepressant, and although it was ineffective for treatment depression, it appeared to increase sex drive. But it was twice rejected by the FDA due to concerns regarding both efficacy and safety, but was approved recently, August 2015, for HSDD, after reviewing additional safety information and most important, after strong efforts by consumer groups. And interesting fact is that 48 hours, within 48 hours of the approval, Valerian Pharmaceuticals purchased the company that developed that year for about $1 billion. So, concluding and based on this data, the clinical role of flibanserin may be limited by the need of daily dosing, the adverse effects, and the lack of safety data regarding interactions with alcohol and some other medication like CYP3A4 inhibitors. And the drug's approval continued approval needs more post-surveillance studies, which are supposed to be completed over the next 1 to 3 years, including several studies that will examine the interaction with alcohol. So we could conclude that flibanserin is probably and unfortunately not the female Viagra. Thank you very much. Any questions? Nothing about the pharmacological treatment. Thank you very much. So thank you for your attention, and there is a talk now? Or? Yeah.
So we will proceed with the last speech of the Congress, which is by Professor Christos Lionis from the University of Heraklion, Greece. He is Professor of General Medicine and chairs the Department of General Medicine, which is General Practice, which is the only department of its kind, I think, in Greece. And will concern the integrating of mental health into primary care, a global perspective or a rhetoric statement. This is a very important issue, especially nowadays with the worldwide economic crisis and the big question whether we can cover all the population in equal, quality and sustainable terms.
Thank you very much, Professor Foudourakis. It's a pleasure for myself in being at the end of a challenging conference. Independently of the number, never paying attention on the number we attend in a conference. That's, I think the most important is the key message that you're planning to spread to the scientific community. And I'm not planning in reading my slides, and I will try to follow your key message that utilizing data and evidence-based in coming across to the key message that I'm planning communicated and spreading to you. But just making a link with the previous interesting roundtable, that's if I asking you, who is the father of mindfulness? Because many times that giving a value to foreign people and entirely ignoring the evidence from ancient Greece. The father of mindfulness is Epicurus. Epicurus, and especially the garden of Epicurus, that's where pleasure was a most important issue that Epicurus was teaching. And I think that it is very, very important. If we just, there are a lot of papers just coming across mindfulness and Epicurus. And I suppose, Professor Foudourakis, that also probably in the next conference, that's coming across the evidence-based medicine based on ancient Greek philosophers. This is my personal conflict. I'm coming quite quickly. Since last days, I think that's last week, and a consultation about mental health reform has been closed. I'm not so very satisfied about the level of communication, and also I'm still thinking that in Greece the major components and the major concepts have not been discussed. According to Epicurus, that's coming back, the most two important issue is the concept. Epicurus mentioned that prolepsis, and also the second, that's given also an excellent memory of cognitive behavior therapy, is the feelings and the thoughts. Exactly that Epicurus was saying many years. And I'm coming back to concept. I'm afraid that in Greece now, but also while, we have not just having a consensus. What we mean by saying patient-centeredness and integration. And I think that is a key word, especially in designing an effective care system. I'm not planning in giving. This is one of the very widely used definition of patient-centeredness. Recently, WHO coming across to from person-centered, from patient-centered to person-centered. And that is very important always, just looking on the patient preferences, needs, and values. And the questions at the moment is, what about the patient's preferences, needs, and values in Greece and worldwide? I think there is a lack of information at the moment. I come in quite quickly, since many models of patient-centered care has been tested outside of Greece, of course, and one of the most specific is just from the Institute of Family and Centered Care, that's saying that is very important, just coming across not only to the patient values, but also to the family values and wishes. Greece is still discussing the reform in mental health, entirely ignoring what's happening outside of Greece. This is the most important change in the policy in United States. Last few years, the Americans decided in coming across to a model named U.S. Patient-Centered Medical Home that's asking all the disciplines, all the specialties together with the providers in working together under the umbrella of medical home and just providing patient-centered care for the whole person, family and preferences, comprehensive care and coordinated care, and that you can see that specialists, hospital and community services needed to communicate effectively together. Introduce also the patient's preferences and involvement in assessing the quality of care, and also just raising issue of safety. Integration from the other side is a second, still non-visible and not discussed widely definition in Greece. And thus you can see that it's a delivery of health services that clients receive of a continuum of preventive, curative services according to their needs over the time and across different levels of a health system. There are many models of integrated care, and unfortunately still not approached in Greece. If you've seen in the Model 6, unified primary care and behavior health. Behavior health is an issue that especially mental health workers could teach them. And unfortunately that in Greece, no any word on how to train effectively primary care providers at the moment, especially in behavioral health, which is a key issue in the Model 6 and the Model 7. I'm coming last day, Professor Fodoulakis from Amsterdam, where a big initiative undertaken by Dutch universities and Nivelle upon the request on Moldavia. Moldavia decided in established a primary care system effective, and decided just a start for teaching the teachers of the primary care providers and mainly the family physicians in Moldavia. And the subject that they are choosing is how we could change the skills, the knowledge, especially in motivating the patients, teaching them motivational interviewing, cognitive behavior therapy, behavior activation, and also common mental health disorders. This was an achievement in Moldavia, but nobody at the moment in Greece started thinking how could implement a mental health reform without incorporating primary care and without started thinking an intensive training of primary care practitioners. Of course, there are many barriers to integration. I'm not mentioning all of that the slides is discussing. Certainly, it's an issue of interdisciplinary collaboration. And now in Greece, unfortunately, we have not just developed such mutual discussion between the disciplines. Of course, there is an issue of new budgetary arrangements, requirements. But also, that's the most important, that the economists study health, is the poor integration of mental health into the curriculum of training of general practitioners across Europe, not only in Greece. This is a diagrammatic presentation of a current focus of WHO to the person-centered instead of patient-centered. I think that this diagram that giving us a sense, this is a joint publication. This is a book integrating mental health into primary care, a few years ago, edited in 2008. It was a joint effort between WHO and VOCA, is the World Association of Family Physicians. That's given in this pyramid, is giving emphasis on self-care. And I'm not as certain, Professor Foudourakis, to what extent, and even in the psychiatric community, self-care has received much attention. Self-care means that the services needed to focus and invest the time and skills in teaching the patients in generally, but also now talking about mental health ill, in just taking over their health without the assistance of specialists or even primary care workers. This is modified by Vonka pyramid and still, to my view, needed attention in Greece. I'm not coming across and supporting why we needed in talking further the mental health integration into primary care. There are many reasons, I'm certain, that you are already familiar about them. But we needed just to discuss a strategy, how to implement this mental health integration in primary care in Greece. Still, Professor Foudourakis, as you know, there are two committees. That's always the same, independently if the past or in currently sees two committees. One expert committee on mental health, that's mostly psychiatrists from academic field, and another committee or experts, mostly from a primary care. I was involved in that. That's focusing on primary care. That is still no any communication between the two experts committee in discussing the integration of mental health into primary care. This is excellent 10 principles or 10 steps that's WHO and VOCA giving in how to implement integrating mental health into primary care. I'm coming quite quickly in the evaluation of primary care, and I'm afraid that the data that recently published outside just classifying Greece in many of the indicators in the lowest position across the European countries. And still, this is a recent publication last year. We just given if Greece are not altered the current situation, I think in all of this accessibility, continuity, comprehensiveness, and involvement and communication, the situation will be worse. I'm certain that you are aware about 2014 data-based economist study. We just was studying to what extent integration in different domains, has been achieved in Europe in 30 countries, 28 European countries, plus Switzerland and Norway. And that a composite index has been formulated, focusing on an environment, on access of the people, mentally ill people, to mental care and social services, to what extent opportunities to them have been given, and to what extent the governments in just deleting the stigma has been achieved. There was a combined methods study utilizing data from big databases, but also just interviews with experts, trying a little bit just to identify and map in Europe. And you are seeing that Greece is among the last position and just overpassing only Bulgaria on Romania. And that's a question, what about psychargos and how many years investment of mental health reform with a focus on community care? What about all of this year investment, achievements, and just giving Greece to that very low position? And of course, that economist study is coming that Europe, it's a spectrum of performances, and independently, if Germany, UK, Scandinavia having the highest overall score on mental health integration, there are still other countries, including Greece, that would be among the lower performing. And the economic study just again focusing and underline the need to the integrated community-based services. But as I said at the beginning, and Professor Fodoulakis, I'm coming to my end, that's the subject that I have not discussed. I'm not criticizing my colleagues or myself. I'm not criticizing the government leaders, since as I'm coming again to Epicurus, they say if the people are not familiar or are not known the concept, that is difficult now just to come into a consensus. And that's the question is, what is about primary care? Everybody and every political party in Greece is discussing about primary care. But if we're coming across, if we're just asking them, to what extent are they having an understanding? What does mean by saying integrated care? What just we're talking or we mean by saying behavior activation? Still the medical faculties at the universities are not coming across is that discussion. Even no any hour at the faculties, even in our faculty, not paying to behavior motivational. And still the primary care physicians, if I am asking in the exams, if they are familiar, what does mean by saying behavior motivational interview, there's no any answer. And more of them, they believe in that they are a theory, or integrated care or integration is an event. Certainly is not an event. Certainly is not a theory. That's now coming at the end. Mr. Kousounis, you missed my introduction when making an introduction to Epicurus. Mr. Kousounis is a philosopher from Corfu, and I'd love in thanking him. Thank you very much in coming there and always inspiring. I think that one of the key issues that we needed as a challenge and as potential bridge between mental health providers and primary care providers is frailty. I'm aware also that Professor Politis is working intensively on that subject. It's a little pity that the European Commission at the moment is spending a lot of money in personalized medicine Horizon 2020 program in discussing frailty. And certainly frailty is not a disorder. It's a combination of disorders. And that's as a result of an isolation of isolated people. They come in and meeting the lack of happiness, especially as a result of their poverty or a result of multimorbidity. That's Mr. Kouniakis on Crete. We decided to come in not in saying wellness, but we decided just describing and composing an index at the moment named eudaimonia. I like very much the term eudaimonia. That's instead of saying wellness or well-being. It's pity that when having the first data from a charitable organization, Professor Kyriazis related organization in Heraklion, and in coming across the data for people having no any access to primary care, I'm talking not continue access, we haven't just identified that especially ladies being isolated or divorced, are already in frailty or pre-frailty, and that's needed an urgent action. Of course, another challenge at the moment is refugees. It's necessary when coming across to the problems of refugees, independently are on arrival or on transition or probably permanently living with us. It's necessary to just start thinking the integration. When building a national health system is needed to just the equity and the quality to be among the major characteristics. This is an operational flow we have already built, having the chance and the privilege in coordinated and SHAFEA program of European Union in preparing at the moment guidance for primary care physicians in how to deal with refugees that they transition. I think that is a challenge that we needed to discuss all together. Based on the first qualitative results, I think that mental health problems, together with disability and injuries, are reported from the refugees. There's data from Moria that Greek team collected, but also data from other 5 settings, including Slovenia, Hungary, Austria, and Italy. That's talking about the mental health problems are among the common problems that refugees are meeting. Professor Foudouliakis, I'm coming to the last 2-3 slides, and among my suggestion to you and your distinguished colleagues that participate in this, I think that we needed to discuss further the integrated model in Greece, and that's the strong collaboration between primary care physicians and mental health. It is necessary, very important, Professor Foudouliakis, just to see, and probably next time, and just we seen the organizational issue, how we could just prepare a training model to the primary care practitioners and giving suggestion to the government. That's started immediately on the basis of the common mental health problems. I think that will be excellent in starting teaching integration and also started thinking motivational interview, behavior, activation, solving problems treatment. This is a book already been published by Springer. I know also your excellent book already situated in gold. We have a chapter on that talking about integrated primary and behavior chance experience from Europe. And also that is a paper quite theoretically that's signed by Professor Ifadopoulos and Professor Chachristas and myself. And if you just read it, somebody, the main key issues of this paper, you can find that also very similar to that the economist just discussing. That economist ended this study saying integration needed just the social support and needed to establish coherent policy frameworks, proper funding to achieve interdisciplinary collaboration and removal structural difficulties. I think this is the last lines, words of economists. We needed to concentrate our suggestion for future Greece, enhancing the communication between primary care practitioners and mental health providers, teachers, and academicians. And I'm hoping that the next conference, Professor Foudourakis will provide at least one unified health team by academicians, by providers, by representatives and delegates of patients. Many thanks for the time and chance being with you.
Next Congress will be very close to Thessaloniki, so we will have much more abilities to have people who know this topic. I have a question. We know how much and to which extent various targets have been met in various countries, various levels and various targets in the integration of primary mental health into primary care and all this stuff. But do we have any kind of output indices? How much this model works eventually? Whether it
yes, I think this is a critical question, and thank you very much. The discussion
because it's costly.
Yes, the discussion about the indicators has been started. We have not harmonized data across Europe. The book that was presented in 2008 just provided some examples from selected countries across the world, not only in Europe. But unfortunately, there is a lack of data in many settings, and this also was a result of economic study that's talking about integration and achievements in primary mental health care. That meets a lot of difficulties because there are many lack of data. Of course, there are data from certain countries which just given to what extent primary care practitioners are able in recognized mental health disorders. Unfortunately, as you are aware, there are certain studies many years ago, if I remember very well, and also recently also from Dr. Randis, and that's already some studies, but in our experience, even some changes in the common panorama, disease panorama in some health centers, still the mental health problems as diagnosis are underreporting. That still, I'm afraid that in Greece we're behind in the UK, when I remember very well in 1965, Wilkinson was just making a study that's published in the British Journal of General Practice, that's saying that British GPs are unable to diagnose mild depression. At the moment that I'm not certain what happened in Greece, and that will be an excellencies. At least we're having some key colleagues and friends from general practice and the Corfu, and probably will be wonderful under your support in discussing a PhD study. We just will collect the data from different settings, but having pragmatic data, and that I think that will be valuable. Thank you.
The next Congress will be neurobiology, psychopharmacology, and treatment guidance. And in the frame of treatment guidance, I tend to dedicate a significant part of the Congress to discuss where mental health goes and where primary care mental health goes. Because I personally, I am very much reserved towards this deinstitutionalization and what has been achieved, not in Greece, but throughout the world. So all these things should be discussed, especially with the condition of the country. What can we do, and what we wish to do, and what we can do.
Yeah, yes, thank you very much. And just mentioning one
Just to
yes,
to
and we discussed in Europe this issue and about the guidelines, and my colleagues were involved in the project of guidelines 2 years ago. And that's to the knowledge of my colleagues in the first fronted line. I'm just suggesting in reviewing the 2015 guidelines of Australian and New Zealand psychiatrists. They published the guidelines utilizing the bio-psychosocial model. And to my view, this is a fantastic review of the existing treatments and models. And that's very relevant to primary care. And somebody asking at the moment, I'm talking about primary care guidelines, I think that this will be. But we need it and follow the proposal of Professor Fodoulakis in discussing more about it probably next year.
Are there any questions? Yes.
I think that we can combine humor with etymology now at the end.
Yes.
This Congress was for evidence-based psychiatry. I would like to ask Professor Fodoulakis if his name means someone risky or not, means risky or not.
My name? Well, this is, of course, it's not the topic of the Congress. There are at least two explanations. One, it's a variant of a very common name in Crete, where the first letter changes from P to Phi. These lips vowels change, and the other is comes from a Turkish word, but the Turks never recognize it, so I'm not sure. There is also in Romanian language, fundul means the risk-taking, the renegade.
So risky outside.
But we are not sure where it comes from.
Yes. May I comment on that? Firstly, in congratulating Professor Fodoulakis, we're utilizing these words evidence-based, independently if evidence-based has not been achieved at the moment. And for those they believe in that are still approachable evidence-based, I'm referring to one excellent paper published 1 month ago. It was a letters between two professors. And one of the founders, as you know, for the evidence-based is Professor David Sahet from Ontario University. And the letter, which just includes a very high disappointment about the achievement of evidence-based, of the approach to evidence-based, because Professor John Ioannidis, at the moment at the Stafford University, I'm strongly recommended to just read this debate. Professor Sahet and Professor Ioannidis, it's just seen where now we're sitting. But thanks again to Professor Fodoulakis in bringing this challenging topic in. Thank you.
We always need to have in mind that there is the way we view a half-filled glass of water is important. You can see it as half empty or half filled. It depends. In my opinion, Ioannidis sees it as mostly empty. This is not the case. And my critique to Ioannidis is that it is very, very, very easy to say that this is not black. Yes, this is not black. Depends on the definition. But it is black. But if you try to, if you put the limit of the definition of color too high, then even this is not black. So we need to be very careful on how we interpret things and what we we receive from the data and the explanation. So I am not pessimistic. I am strict, but I am not pessimistic. We know things. The most important thing with, and with this I want to close the Congress, the most important thing with evidence-based approach is not being negativistic. It's to identify the dark corners and the black spots of knowledge, what we don't really know, but we think we know, and what is wrong in our everyday clinical practice, why our patients are not doing well. They are supposed to be doing much better than we see. Why is that? This is because there was an enthusiasm during the 50s and the 60s. Psychoanalysis triggered a wave of enthusiasm. The same happened with medication, with antipsychotics and antidepressants. We know today that psychotherapies do not work that well, and we also know that the enthusiastic reports from the early trials of antidepressants and antipsychotics were false. A lot of data were not really reported. I think nobody knows really that the first trial of clozapine in France with Deniker resulted in 4 out of 18 deaths. 4 patients died out of 18. Nobody discusses this now. Nobody discusses that how effective could 50 or 100 milligrams of chloropromazine could have been in psychotic agitated patients. Probably these enthusiastic reports were because it was the first image of something that we hoped will come, something different in the dark of these years, when only electroconvulsive therapy was an option, and insulin and metrazole treatment were very, very dangerous. So today we know that we cannot rely on enthusiasm. We can rely on knowledge and specific measurement and assessment. So with this, which I hope it's optimistic, it's an optimistic view and a guidance for the future, I would like to close the Congress. Thank you all for being here with us. Thank you all for attending the Congress through the live stream in YouTube. Many of the speeches, depending on speakers' wishes, will be uploaded in YouTube. You will find it within 1 or 2 months. Thank you all again, and hope to see you next year, last weekend of May in Chalkidiki. Thank you.